Um, a big thank you to COVID Action for organizing this and indeed for inviting me to chair. It's a great pleasure and privilege to do that. And I look forward to a really interesting and productive discussion. Okay, so just by way of introduction, I'm assuming that everybody here is fairly well informed about COVID and the basic means of transmission and the various difficulties that we've all had in trying to get some kind of sane and rational policy to address and tackle this pandemic. Um, but it is quite extraordinary that here we are in November 2023, where we are, as a society, turning our backs on proven science and knowledge in public health and infectious disease control, away from things that we know work into some kind of denial and head in the sand approach to a level 3 biohazard, which is causing major problems for us as a society, and in particular, people who are vulnerable clinically, immunocompromised, disabled, and so on. And I think many of you will share my disbelief at this state of affairs, but this is where we're at. And it's really important that we continue to challenge things and not allow the minimizing, gaslighting, and ongoing, relentless narrative that it's all over, it's nothing to worry about, and let's just get back to normal, because we all know that that's not the case. Infection control policy, or the response, the national response to the pandemic is now officially, I believe, one of surrender and capitulation. Jenny Harry said a year ago in the Houses of Parliament in the Select Committee, we are not trying to stop total transmission. We're going to treat COVID-19 like any other respiratory virus. I was in a meeting with an IPC team from an NHS hospital trust several months ago when they said, nationally, it's recognized we're not going to eliminate COVID-19, so we're going to treat it like any other respiratory disease. And so there is a drive to somehow squash COVID-19 into the same box as influenza and RSV, respiratory syncytial virus, and tell us that it's a seasonal virus and it's no worse than those other respiratory diseases, which of course we know is completely wrong. There are lots of other things happening as well. Just earlier this week, there was an editorial in the Journal of American Medical Association, one of the top medical journals in the world, with a headline, "Is it worth preventing hospital-acquired infection of COVID-19?" So, it's not like it's a static situation. The more this minimizing and denial agenda proceeds, the more people want to extend that to take away even the remaining planks of policy to try and tackle infectious diseases. And I think what we're seeing is in fact, the beginning, and perhaps more than just the beginning, of the dismantling of public health, or the basic principles of public health, certainly in terms of infectious diseases. But I think it's leaching out into other areas as well. We've seen things like there's been a measles outbreak in Cardiff recently because of falling rates of MMR vaccination. The actual booster campaign for COVID has stalled at around 50% of eligible groups. Those are the eligible groups. And vaccines now, which are almost not useless, but very limited efficacy against the latest variants. At the very center of this, I believe, are the infection control guidelines. And Evonne is going to tell us a lot more about that. But these are at the center of things. And every time that we challenge existing policy and practice in hospitals and healthcare, we are told, oh, we're following official guidance. And that is not enough. That is just simply not good enough. Official guidance are not scientific. they're based on dogma, and they ignore airborne transmission. And I think it'd be good if we could, perhaps in the discussion, talk about how we best tackle that. We know what works. We know what to do. We have the technology to do it. It's not rocket science. It's been around for decades, actually. Masks work, air filters work, better ventilation works. We know this. But for the reasons that I've mentioned and several others, which we'll talk about, the official response is to deny that and refuse to implement those mitigations. We must continue to make demands on our governments and the institutions that have the power and authority to improve things. We know they're not doing it, and so far the door has been locked and barred. But I think it's really important that we continue to bang loudly at that door. But I think we need to realize that those institutions have failed us, and we cannot rely on them any longer to and expect them to implement change. I think we have to start organizing and start effecting change ourselves from the bottom up. And I'm really pleased to see that that process has begun and is in fact gone some way along that road already in terms of getting organized and bringing together people who are working on air filters in classrooms, on demanding masks back in healthcare, and so on and so forth. And there are a lot of campaigns that are taking place, not only in this country, but internationally. Okay, so I won't say any more. I think that's perhaps enough of an introduction. I'm delighted to introduce you to Evonne Curran, who's a retired infectious diseases nurse and a real expert in that field. And it's been a real pleasure and privilege to get to know Evonne over the last several years as a person, one of the few in the infectious diseases world who has stood up, raised her head above the parapet, and has been shouting loud and long about this, that our approach is completely wrong and we need a much better, more scientific approach. So over to you, Evonne. It's a real pleasure to introduce you. Thanks.
Thank you very much for that very kind introduction. I'm going to share my screen and we're going to see if technology works. That seems to work. Boom, right, hands up. Okay, so I've got too many slides for 10 minutes, but we'll get through them. So I think I started with, where the heck are we? And there's a very good definition of a mess, which isn't just that you've spilt the tea on the floor. It's a situation that is confused and full of problems. And I would argue that is where we are. And I was at my lowest ebb just a couple of weeks ago, listening to what was being said at the COVID inquiry and realizing that they all knew. There was no point in all of the research that I had done presenting evidence to counter this and to counter, because they actually all knew it was airborne all along. But no organization has shown regret, reason, or remedy or change. But I do like the Longfellow poem that, although you might be at the lowest ebb is the turning of the tide. So let's see if we can turn the tide. So I'm just going to present, just going to give you some understanding of the problem and some potential approaches that might be useful. And as Jonathan mentioned, what is COVID? And that's not written anywhere at the minute. There is nowhere in UK guidance that's got an up-to-date description of COVID. So people think it's a respiratory virus, a winter virus that's no more harm than influenza. Long COVID's not a thing. At the other end of the spectrum, people with a brain who are reading the literature are saying, no, this is coagulopathic, vasculopathic, neuropathic, immune damaging, blah, blah, blah. But down here, something I found out the other day, it's the biggest nosocomial infection threat. And you might say, show us the data. Okay, then. So there are a lot of infections which hospitals or trusts or boards, whatever you like, are mandated to collect. So they must collect this data as an indicator of overall infection control. So these are bloodstream infections by and large, apart from CDI you might have heard of, is a gut infection. So all these different bloodstream infections, here they are, all down here. Now, I can't see my one here. The last time COVID was counted for a year, nosocomially, it came out at 83,000. So if you add up all these infections here, you get this. And if you treble that, you still don't reach the number of nosocomial COVIDs that were happening by the year. And I don't believe that involved healthcare workers. Now, there's a very good book by Paul McGee, and it's How to Speak so people really listen. And one of the things he does is he makes you envisage a beach ball, and he says, what color is the ball? And what color is the ball depends, where are you looking from? Because we might all be over here thinking it's a blue ball, because we've seen the evidence, we know it's airborne, we know it's spread, we know it causes long-term sequelae. But over here in the don't give a monkey is going to carry on my lifestyle, the ball is yellow. And up here, it's not going to cost me any more money. The financial people going, sorry, this ball's red and we've paid enough as we go. So what color is the ball depends on when you look. And then when you're trying to affect change, you have to know what color the ball is. What color do they think the ball is? You know what color the ball is, but what color do they think the ball is? And so if you take a look at the people, so over here we've got healthcare workers who maybe not up to date on what's going on. They've been through hell with the COVID working in, and they just want to get on. They're following the guidance. They're looking at one color of ball. The bed managers will look at the ball in another way. It's whatever it takes to keep the service running. And then you can argue that this is over here. These are the people that know we need ventilation in schools and we need better ventilation in care settings. I think here is who are here, public health. I don't know where they are. But here, all these people here, these national committees, these managers, they're all relying on the national guidance. Everyone is relying on the national guidance. And as long as that stays in place, it's fine. If that got changed or altered, there's an awful lot of things that would fall apart. Now, I did a kind of, right, what are the hurdles to us getting safe practice, if you will? And I could have done more, but I ran out of space on the page. But there's three that I think are important. Most of the NHS is designed to spread COVID now, or spread the virus. Now, there was an engineer at one presentation I was at, and he said something like 55% of the estate didn't comply with the guidance for air. So that's a big problem. And there's another problem up here, and that's, I think, one of the problems we've got with current healthcare workers. They will have had to have gone through things in COVID where they made decisions they would not like to have made. And once you have done that, it's very hard to go back and say, we don't need to do those sorts of decisions anymore. We can make much safer decisions. So that's very hard. And this one here is, there's no accurate situation awareness of what COVID is. It's not there. The information that was released the other day on the risk assessment for who gets a vaccine considered only that COVID was a respiratory disease. That's a problem. We need recognition that it's much bigger than that. But to contrast with that, I did a kind of, okay, well, what's the doors? What are the doors that are open to us and to organizations trying to make it safe? And I think one of the big ones is the code of practice. So I'm going to talk very briefly about that. They can't change the fact it's a hazard group 3 pathogen. That's big. That's tuberculosis. You can't change that. And we've also got the other one that the literature's clear, the guidance and the precautions are wrong. So there's lots of great evidence, but there are other things there that can be used. So here's some potential solutions. You know, I wrote something for Jonathan the other day, and it's 14 pages. Now, that's great to put everything down in 14 pages, but actually, if you want to communicate with someone, we need to sum it up in one sentence. And where you are coming from, whether it's clinically vulnerable people, whether it's people in your organization, in a union type organization, what in one sentence is the sentence they're going to stop? For me, I've always looked at it from a nosocomial hospital-acquired infection type thing, and I would say that COVID, COVID's the most significant HAI in terms of numbers, morbidity, and mortality. And when you put it like that, people have nowhere to go. If you've got the data to support that statement, because they won't have data to counter it if your data is correct. So think about what's the one sentence that could describe where you are and the problem. And this is a Pareto chart. It's the same chart I showed you before, but it's as a Pareto. So we need to illustrate the problem. So the link is there if you want to get this data here is the 83,000 that was done by Tom Lawton. But here's all the other types of infections. And when you put it like that, how can you not even attempt? And also saying, you know, when I remember when MRSA was a big problem, the man that used to be the director at Celtic, was it Reed? He said, if you don't lower that by a half by next year, directors will be going to jail. Now that's how you start a conversation to tackle a problem. Now this is an extract from the Code of Practice. And so every registered provider must comply with the Code of Practice. This is the English one, but there's a similar type one in Scotland, but it says you've got systems to monitor the prevention and control of infection. So how are you preventing and monitoring COVID? Well, we're not doing it at all. So I think this is about get their documents with which to counter their arguments. There's another one here that says there is a policy for ensuring that people who are at risk of developing an infection are identified promptly and received appropriate treatment. Now, to me, that means if clinically vulnerable people are my patients to come in today, I do something different. But there is a problem, and that's the link to the act there. And that problem is the National Policy Manual doesn't recognise clinically vulnerable people. And so, people say we're following the manual. So the manual, as Jonathan says, be it Scottish or English, they're not heap of the difference between the two of them, is where we must tackle and get sorted. And I think anything you're going to do, make it simple and illustrated. This is one I did of Trish Greenhalgh. These are the 10 reasons that it's airborne, that can't be counted. In fact, Trish Greenhalgh asked for a copy of this because you want it explained in as few words as possible. And somebody else said, yeah, you forgot about the bus. It went backwards 5 meters on a bus, and droplets won't do that. Again, very simple things to show how it spreads. And we don't have a lot of this. Some people do, some organizations, but it comes from the air via people, and it can then go from people to people. It can go from healthcare workers to others in a close space or far afield. And knocking the hand hygiene on the head and the surface cleaning, if you just, normal hygiene will do that. It's not a problem. I think we have to make it desirable to do. This will benefit you if you follow this. So that's a kind of standard approach. So if you prevent healthcare worker to healthcare worker transmission, you're going to reduce sick time, long-term illnesses, all of this stuff you're going to do for them. The problem being is they haven't got the numbers for today. But if they can manage today, they will be able to do it much better in the future, and obviously decrease morbidity and mortality for patients, particularly those who are vulnerable. I got a reply back on one thing from a cheeky person: we have robust procedures. Now that's a bad thing, somebody saying that. And what I would say is, right, you've got to avoid confrontation, take out the emotion, be persistent and consistent. Thank you. It's excellent you've got robust procedures, but can you tell me, can you explain to me to understand how your robust procedure omitted this in their decision making? So it's getting it to them. You want to walk them down a line where they can't go anywhere, but eventually someone's going to put their hand up and say they were wrong. This might look like a technical slide, but let me tell you, the WHO and CDC said droplets don't go further than here. The Department of Health said they get to here. And the latest transmission-based literature review said they get here. That's nonsense. They all can't be correct. So highlighting stuff which I say fails the DIMS test, it doesn't make sense. It is quite useful. And I talked about that Pareto higher up. What's the biggest problem you're going to tackle? So what you want to get out of them is, where's the problem manifest most? And that, if you're in a sort of, somebody mentioned about unions and office buildings, where does it happen most? Right? It might be clinical areas, it might be certain areas. Who's in a crowded area for most risk at the time? And what's the biggest risk? Is it going, well, I'm going past patient to patient, healthcare worker to patient, healthcare worker to healthcare worker, or patient to healthcare worker? Now, in an office sense, that would be something different. But where's the biggest risk, and where's transmission most likely? And if we Pareto it, you never go from a really crap situation to excellence in one go. That doesn't happen. You do steps, but you start with the biggest and you'll work it. Now, I'm not going through this, but basically I'm saying, right, okay, if it's down here, if it's patient to patient, that really suggests it's the air and it's far afield. What are you going to do? There are options. So have plans for what you can do in certain situations when you've worked out what it is, and it will involve ventilation. And showcase what's brilliant. This is actually one by Joey Fox, and it shows you all the things that you should do in schools in Canada, I think it is. So where's the one for hospitals? So where's the one for schools in Scotland, and or what have you, or offices in Scotland? That kind of thing, making that kind of thing expected to see. You used to have that old health and safety work act thing on everything. That'd be much more useful than the health and safety at work act. Useful to play the daft lassie or the daft laddie. You know, okay, if droplet precautions are all we need, why is it going up? And what they did with that was stop the data. And finally, I think somebody's got their microphone not on. But finally, there's a very useful theory called high reliability theory. And it's worth getting into, because what you get when you understand this is that people are being very superficial with their responses and they're not being reliable, and you can use it to go back to them. So I'm going to stop there, and hopefully, where are we? I think hopefully we're at the turning of the tide. Thank you, Jonathan. I'll hand back.
Thanks so much, Evonne, for that great presentation. A real whistle-stop tour and a lot of information packed in there. There was a number of requests in the chat. If you wouldn't mind sharing your slides and the references and things, would that be okay?
The slides have got the links on, and the slides will be made available.
That's fantastic. Thank you. A number of very important issues that you raised there. I mean, the scale of hospital-acquired infections compared to the others it's just off the chart, literally. But yet there are national conferences about MRSA, and COVID doesn't get a look in. It's quite extraordinary, the willful blindness that's being practiced. Quite extraordinary. Okay, and the other thing you talked about was the different lenses through which people look at the problem. And that's a nice segue, as the Americans like to say, to introducing Natalie, because Natalie Bain-Reguis is an expert in buildings performance. And I'm so pleased that COVID Action Scotland have invited Natalie, because we know that the solution to this pandemic is not going to be enough if we rely on biomedical science only, i.e. doctors, nurses, and infection control. This virus is airborne, and the science of the air and the way the air moves and the way particles in the air moves is the physical sciences, engineering, physics, chemistry, and so on. And Natalie is an expert in that field. I just want to get up your official title, Natalie, if you just bear with me. So Natalie is a research associate and doctoral candidate at the University of Edinburgh Napier, and has spent a lot of time looking at the performance of buildings and how to keep them safe. I believe mostly in schools, but you know, the air is the same everywhere, just about. There will be special areas within hospitals, but by and large, I think the problems are the same. So a warm welcome to you, Natalie. Thanks so much for joining us.
So I'm going to present what I've done since the pandemic has started. So, and to put that into perspective, I'm going to say that in 2020, I was about to start a study on indoor air quality in maternity units. But because of the pandemic, I could not have access to the NHS facilities. So I've tried to do the same type of studies in schools. And I'm going to talk about carbon dioxide levels, ventilation, visual sensors, and comfort, health, and well-being of the teachers in schools. And hopefully the lesson learned from this study could be transferable, applied to healthcare settings as they are with schools, busy and crowded indoor environments. So first, here are the Scottish regulations in schools as of in March 2020. So the indoor temperature has to be 17 degrees minimum, the ventilation 10 liters per second per person, and the CO2 levels needs to be below 800 or 1,500 ppm, depending on the activity. So sports halls and music rooms need to be under 800 and the other ones below 1,500. Measuring the CO2 levels gives a good indication of how well a space is ventilated. That's the reason why we are looking at CO2 levels. And well, it's well documented that the CO2 levels in classrooms are usually above the 1,500 ppm. So after a few months into the first national lockdown, the City of Edinburgh Council wanted to identify which of their schools had poor ventilation and asked us to do a survey of 50 classrooms from 9 schools with different archetypes. So they could be from the Victoria times up to 2009. That included primary schools, high schools, and special schools. 7 of these schools were naturally ventilated and 2 were mechanically ventilated. We measured the indoor temperature, relative humidity, and the CO2 concentration. It was done over 1 week in November and December 2020. The teachers of the classroom were asked to give feedback on the number of pupils and opening of the windows and doors. That was to calculate the ventilation rates. The details of this study are in a report made to the City of Edinburgh Council, and it has been the object of a peer review article where you can see the title there. This study and its conclusion has been mentioned during a parliamentary session in February 2022. And basically, this study showed that 28% of the classrooms had CO2 levels above the threshold of 1,500 ppm. So that's, and 40% had an average indoor temperature below the 17 degrees. Mechanically ventilated classroom with well-maintained systems had lower CO2 levels. So the following recommendations were given to the council. 1, all mechanical ventilation systems and manually operated windows servicing classrooms should be checked for correct operation. 2, ensuring lower occupancy levels in classrooms whenever possible. 3, open as many windows as possible during class time and as well as the classroom door to try and stimulate through ventilation. And 4, flush the air by opening fully all windows and doors during break time and at the end of the school day. So after that, there were some aims and other studies to be done. And so I've asked if I could follow up this first study and looking at the impact of visual feedback of CO2 sensors on the indoor environment and on health and well-being of Scottish teachers. To present the study, let's go back to some facts. So in March 2021, the Scottish government announced they were giving special funding. So it was £10 million to the local authorities to buy CO2 sensors to be deployed in their school classrooms. The second point was visual sensors, which help occupants visually monitor their energy consumption, have had positive outcomes with reduced energy bills. And the third fact is that the teachers are the ones who suffer the most from stress, anxiety, and depression, and have an increase in work-related respiratory problem. So the aim of the study was to explore the effect on the indoor air and on the teacher's comfort and behavior change when raising awareness of the influence of the indoor air and on ventilation, and also when the teachers are using visual CO2 sensors in naturally ventilated primary school classrooms. So the research questions were, can visual CO2 sensor help the teachers improve the indoor air quality of their classrooms? Can we ask the teachers to be in charge of managing the ventilations of their classrooms? And can CO2 sensors have perceived health benefits for the teachers? So that's the study design. So considering the findings of the initial study, showing that the primary schools have higher CO2 concentration and the City of Edinburgh Council manages 89 primary schools, 90% of those are naturally ventilated. We decided to study 2 similar comparable Victorian primary schools with natural ventilation. And the council agreed to provide access to 2 of their schools which met our criteria. So Victorian primary schools naturally ventilated in the same type of environment, and the schools who are willing to take part in the study. So we had two schools, T and S, in the center of Edinburgh. They were quite close, 2 miles apart only. The study took part for almost one school year, so October 2021 to June 2022. 26 teachers have been involved, 11 in T and 15 in S. And so what we have done is that 10 classrooms of the school T were equipped both with visual and non-visual sensors measuring CO2, temperature, humidity, and 10 classrooms of school S were only equipped with only non-visual sensors. All the classrooms were visited weekly and visual observations were noted. The teachers were asked to participate in 2 online surveys, one in October and one in March, and the aim was to understand their perception of their comfort, health, and well-being in their work environment. So the first point of action that we took was to explain the aim, obviously, and the objectives of the project, but also to create a webinar to raise the awareness of the teachers around indoor air quality. So that has been done in collaboration with people from the TAPAS network. So TAPAS stands for Tackling Air Pollution at School. And so a 60-minute webinar has been created explaining important elements such as what is indoor air quality, the influence of indoor air quality, was it an airborne virus, how is it transmitted, why are we using CO2 monitors, how to use them, and so on. And so you've got the link here to the webinar. On the right of this slide, you can see what a visual sensor looks like, and we have bought exactly the same ones that the City of Edinburgh Council have bought for their school, so the teachers knew already what they looked like. So the findings on the CO2 measurements. Here are 2 graphs showing the time-weighted average of the CO2 concentration over the course of one school day in a heating season, so on your left, and the non-heating season on your right. The blue line represents the results for the school T, which had visual sensors in their classrooms, and the orange line represents the CO2 levels of the school S without visual sensors. It is noticeable that the CO2 concentrations are lower in school T when the classrooms have got visual sensors. And that's the case even if there is a slight difference between the 2 seasons, that's the case in both seasons. Now let's have a look more specifically at the levels during the heating season. So the following 2 graphs show the average of the CO2 concentration on the left and the indoor temperatures on the right, because the argument is that if we are going to reduce the CO2 and then enhance ventilation, people are going to be too cold in their classrooms. So we wanted to look at that as well because it's a comfort element. So the same colors as in the previous slides have been used. So meaning that the orange, it's without visual sensors, and the blue, it's with visual sensors. And the classrooms have been organized from the smallest CO2 average to the biggest. So looking at the CO2, you can see that the school T with visual sensors have got average, the average are lower than the school S. 4 classrooms with visual sensors have lower average CO2 than the average of the school. But that doesn't mean that in the same classrooms have got very low indoor temperatures. That's what you can see on the graph on your right. Now, I just wanted to illustrate one specific classroom, which was in the school with visual sensors, and this classroom was T7. And this represents the CO2 levels for the whole year. So you can see it's usually below 800, barely above 800 all year round. And then at some point, it's very high. So what happened at that time, because I was going every week for my weekly observation visit, I noticed there was a supply teacher on those days. Actually stayed for more than a week. And this teacher was unaware of the webinar. He was not aware of the ventilation strategies. He was not using the CO2 monitor because he didn't know how to use it, or he'd not even been made aware that he could use it. And again, during my weekly visits in school T with the visual sensors, I've been approached by different teachers as including the usual teacher and the classroom T7. She had issues with one of her blind. You can see on the picture on the left that one blind is down, and it's just because it was broken, and she could not move it back up, meaning that she could not ventilate properly on this side of the window. But I did notice each time I was going every week that she always opened bottom and upper pane. And actually she told me, and others said the same, that since she has been watching the webinar, she had put in place a strategy to have good ventilation without lower temperature. So because they had this opportunity with those sash and case windows, that she always kept the upper pane open to have good ventilation, and the bottom pane open not to be too cold. But when the CO2 levels were going too high, then she was opening also the bottom pane. So she was just playing with opening and closing the bottom pane. And that's the reason why she has managed to keep the CO2 levels low and the thermal comfort acceptable. Now moving on to the findings of the survey. So having sensors had no impact on the perceived health symptoms of the teachers, nor on their perceived overall indoor work environment. And that was true whether the sensors had visual feedback or not. In contrast, the sensors had significant impact on more specific indoor parameters. The teachers from both schools felt the sensors were positive tools to enhance air freshness, air or odor, air cleanliness, ventilation, and overall indoor satisfaction. But teachers reported that having sensors had a negative impact on the air movement in their classrooms, as more windows were open implied more air movement to the point of feeling too much draft. The teachers having visual feedback sensors in their classroom reported that they felt the sensors implied a reduction in their indoor temperature. No impact is observed on anything else where they had questions on compassion, satisfaction, burnout, and secondary stress, and there was nothing special to report on that. But having sensors with visual feedback had a negative impact on the teachers from school T in general. The possible reason can be related to the added pressure to look at the device to check if more windows or doors needed to be open. And they also said that their pupil could also notice the value of their device and interrupt the class to see if when the data were becoming too high. So they did say, the teachers did say that it was adding pressure to their workload because they had also to manage the indoor environment, and it could be a distraction to the pupils. So in conclusion, we can say that raising the awareness of the teachers about good ventilation practice for their own classrooms improve their indoor quality as quantified by reduced CO2 concentration. More ventilation reduced the comfort level of the teachers during the heating season. They find their indoor working environment less comfortable and colder more frequently in winter. The visual CO2 sensor helped the teachers who had them and used them to improve and maintain lower CO2 concentrations. And the visual CO2 sensors could have been disruptive during class time and have been the source of additional work-related pressure. And that's me.
That's great. Thank you so much, Natalie. That was really informative. I'm fascinated by the studies, actually, that you've done, because it's something that I've personally wanted to try and get going in a workplace using health and safety representatives of trade unions. And it'd be great to collaborate on that. Your advice would be so helpful. But I just wanted to. Great, thank you. I mean, I'm sure people in this audience understand why CO2 measurements and improving ventilation is so important. We know it's airborne, but I think what's not appreciated so much, even within, if I can call it, the COVID-aware community, is the nature of airborne transmission. It's not only one-to-one spread from one individual to one or two other people in a poorly ventilated space, sometimes even in a well-ventilated space if you're close up to people. The main driver of this pandemic is super spreading events. We know this is well documented in the literature now. There are lots and lots of papers demonstrating this. So that is why ventilation is so critical in our response. And by ventilation, I also include, by the way, the use of air filters, because they will give us equivalent air changes per hour of clean filtered air, because that will reduce substantially the spread from one or two infected individuals to whole groups of people sharing that same indoor poorly ventilated space. Improved ventilation also does diminish the one-to-one spread, even if you're fairly close up to somebody. There's a very good talk by Professor Jose Jimenez, whose people may know, who's a US based aerosol scientist, one of the top guys in the world on this. And he reckons that air filtration and ventilation will get rid of super spreading, distance spread, and about a third of the spread between people in close proximity. So even without masking, it does have an impact. But masks are still necessary. He also emphasized how important the visual display is in terms of taking action. Because if you don't have any sort of monitor showing you what the CO2 level is, you don't know what the ventilation is like, unless it's absolutely dreadful, where it feels, stuffy, and just by being in the space that it's poor. Okay,